Okay, so I'm here to talk about common foot fractures. I guess the good thing is that we're ending with this, so hopefully I can provide a practical approach to managing the common foot fractures you're going to see. So we'll first start out with talking about a little bit about biomechanics. Now, the foot's a little bit different. It's always in motion when you're walking, and there are a lot of articles talking about what exactly happens between the three zones of the foot, meaning the hind foot, the forefoot, and the midfoot. The bottom line is that they all work together in 3 dimensions, and if I can make this run here. So this is a live CT view of what happens when you are moving part of the one part of the heel and the midfoot and the forefoot. They all work in unison. So if there's one injury to one part of the foot, it will most likely affect either down the forefoot if you have anything in the hind foot, and the midfoot if you have anything with the midfoot, it will affect the subtalar joint and so forth. So the bottom line is establishing a stable platform by really looking at your length and rotation and making sure that you have everything intact, and establishing this continuity between the 3 zones of the feet. Now, when you're talking about foot injuries, they're all really grouped into couple of mechanisms of injury, both direct and indirect, like any other injuries that you see in the foot and ankle. You have the direct injuries from car accidents, crush injuries, industrial accidents, and you have the indirect, mostly from sport injuries like twisting, forced, what we call dorsiflexion and plantar flexion, and inversion and eversions. Then when you see these folks, they're all swollen. They all have tenderness where the bone is broken, or even global if it's more, or if the energy is a little bit more advanced. They all have limitations on their range of motion, and they may or may not have deformities and wounds. So I always confirm with X-rays. If you can get weight-bearing X-rays, that's the gold standard. If you can't, then you have some stress views you can use for if you're concerned with ligamentous injuries. But the bottom line is they all get X-rays, and in some injuries, if you're not sure, you get CAT scan as well to confirm. So if you think about like the actual numbers of what's common, you're talking about metatarsal fractures. That pretty much composes of 35 to 40% of all foot fractures, and about 5 to 6% of all skeletal injuries, ranging between the 2nd to 5th decade. And they're really grouped, based on where they are in the foot. The border rays, which are the 1st and the 5th metatarsals, are grouped separately from the central 3rd. Now, if you go through each one, the 1st metatarsal, which is the least amount of fractures you're going to see from a metatarsal standpoint, they're the biggest one that supports about 35 to 40% of the body weight. And what's unique about it is that you have strong tendons attaching directly dorsal and plantar to it, which are the anterior tibialis tendon and the peroneal longus tendon. Also, the 1st tarsometatarsal capsule is strong, and it supports the actual arch in a resting position. Most of these, when they present into your office, or if you see it in the ER, will be non-operative, because most of them are minimally or non-displaced. And so when you see that, you immobilize them in whatever you want, cast, boot, surgical shoe, and you pretty much make them non-weight bearing for about 4 to 6 weeks. And you progress their ambulation, you wean them off the boot based on healing at that point. But when you do see a 1st metatarsal that's angulated, and you're going to see the same for pretty much all the metatarsal shafts, angulation greater than 10 degrees in any sagittal plane, or displaced more than 3 to 4 millimeters, especially if there's any shortening or rotational deformities, then you start thinking surgical fixation. Now here's an example of a non-operative case. As you can see, the proximal shaft of the 1st metatarsals, minimally displaced, really non-angulated on a lateral plane, and this goes on to healing in about 4 to 6 weeks, where you would progressively weight bear them from then on, weaning off the boot to a sneaker. On the other side of the coin, this shows shortening as well as comminution, and this actually involves the articular surface, where you can't just leave that alone. As if you leave a short metatarsal alone, you'll have a significant amount of plantar transfer metatarsalgia, and the overall gait mechanics that you saw with the first dynamic CT won't be restored. So in this case, this was fixed by a spanning plate, and really the plate normally used for this, 3-5 plate. I think the modular foot sets that you see might be too small and definitely not strong enough to hold this out to length and bear the weight eventually when you start getting them going. The central 3 metatarsals supports about 10 to 15% of the body weight. These are inherently stable due to the plantar and dorsal interosseous support. They're also supported by 3 ligaments at the base, very thick, centrally, dorsally, and plantarly. The second and third metatarsals are normally more rigid than the fourth. You'll see more stress fractures in the second and third with overuse because of that very reason. The fourth metatarsal shows more mobility than the second and third. It allows for more adaptation to terrain, along with the fifth metatarsal that we're going to talk about in a sec. But when you're looking at these, most are non-up as well, even if they're continuous metatarsal fractures. In other words, if you have 2, 3, 4, most of them will be stable if they're non-displaced. And again, they're immobilized in a cam boot for about 4 to 6 weeks, and based on their healing, you then progress them to full. And here's the mantra again. Surgical indications are angulation 10 degrees in the sagittal plane, displaced about 3 to 4 millimeters, and especially shortening and rotational deformities. Here's an example of a non-operative case. Here's a non-displaced fracture of the second and third, minimally displaced in number 4, placed in a cam boot, and in about a month, you see healing in 2 and 3, and 4 is still lagging behind, but this case eventually went on to healing. On the other end of the spectrum, these are completely displaced, rotated, shortened second, third, and fourth metatarsal. And for these, if it's distal enough, I treat them with K-wire fixation. Now, for those of you who've done this, it could be a bear doing it. It looks easy, but sometimes the interosseous muscles gets in the way, and it's hard to reduce just by pulling on the toes. Sometimes you do have to open them. If you do open them, you make a dorsal incision directly over the fracture site, retracting the tendon, and really holding it with some sort of freer elevator and retrograde pinning this from the head of the metatarsal into the shaft. Now, I keep these pins in once they're fixed for about 1 month. I pull them in the office, and then I start the range of motion of the toes at that point. I don't allow them to move their toes as far as active and passive range of motion until I pull the pins out. And obviously, they're walking on their heels or not at all. Here's another example of a surgical case, multiple central metatarsals, shortened, especially number 3 and number 4, if you look at this case. Again, pins. And the size of the pins, either a 0.045 or sometimes if the metatarsal is big enough, you could go with a 6.2 K-wire in fixing these. Sometimes you would need to use plate fixations, and this is an example of a second metatarsal that's shortened. So in this case, the approach is dorsally and using any modular foot plate that you have out there that's about 2.4 millimeters. A few things that I like to do, spanning the whole metatarsal to extend your fixation. And you don't really need more than 2 screws proximal or distal to it. The most common metatarsal fracture you're going to see is the fifth metatarsal. It supports about 5 to 10% of the body weight, and it's the most mobile of all the metatarsal. You have tendinous attachment, your peroneal brevis at the base, and as well as the plantar aponeurosis plantarly. Occasionally, you see a tertius tendon inserting dorsally. When thinking about the fifth metatarsal, you're thinking about how the proximal part is classified. It's classified based on the vascular flow and the capabilities of healing. And this, certainly the fifth metatarsal, is what's getting all the press as far as what the common fractures are doing. And so Torg classified these into 3 zones, again, based on the ability to heal. Zone 1 is the base, where you do have your peroneal brevis attachment and your plantar aponeurosis attachment. Zone 2 is really the articulation between the fifth and the fourth metatarsal, and there's a lot of plantar ligaments attaching to it. And 3 is more of the proximal shaft, about 1.5 centimeters, extending 1.5 centimeters distal to zone 2. And then when you look at the blood supply, and everyone knows this, there are 3 blood supplies to the fifth metatarsal. You have your metaphyseal vessels, and you have your nutrient arteries supplying it dorsally. Now, the issue is, and also the periosteal vessels, which is not here. Well, what happens is if you break the fifth metatarsal in zone 2, you then create an avascular zone in this area. So back to zone 1, this is the most common fracture you'll see in the fifth metatarsal. Again, it's at the base. It's about 93% of all fifth metatarsal injuries. They have great healing outcomes with non-union rates reported at 0.5 to 1%. There's really no difference in how you immobilize this thing, whether it's with cast, boot, hard sole shoe. I particularly use a boot because of the insertion of the perineal brevis. And surgery is really rare. The literature talks about 3 millimeter displacements, but I'll be honest with you, if I see a fracture like this, that it's minimally displaced at the base of the fifth metatarsal, I leave it alone, and we just wait. And I don't even follow DC union. And a lot of times in the fifth metatarsal base fracture, once they're pain-free in about 4 to 6 weeks, I start letting them go as far as activity-wise, and I don't follow this to completion from a radiological standpoint. But sometimes they do still have persistent pain, 2, 3, 4 months down the line, which is what this case is showing you. This is about 3.5 months post-injury. This patient, maybe there's a little bit more distraction there, but that's definitely not 3 millimeters. The bottom line is they still have pain, and then what do? So you have options on how to fix this. You could excise it, and maybe you could transfer whatever perineal brevis attached to this little fragment and inserting it to the bone. You could fix it with screws, or you could do what I like to do, which is plate fixation. So in this particular case, I use the concept of the hook plate in compression plating this fifth metatarsal. And I don't really use biologics for this because, again, you're looking at an area that has a lot of blood supply. I save the biologic for the fractures we're going to discuss next. Now, zone 2 and 3, again, we're grouping it together because it's an area that doesn't have a ton of capacity for healing, at least not predictively. Zone 2, again, it's the articulation between the fourth and fifth metatarsal, and zone 3 is proximal is distal to the proximal ligaments. Now, if it's non-operative, it's usually for the non-displaced fractures, and I usually keep them non-weight bearing. I think that's a key thing for about 6 to 8 weeks. You wait a little bit longer. However, there is some controversy out there for more active patients or the super athletes that have non-displaced fifth metatarsal fractures. However, there's no consensus for fixation. Some do it to try to speed up the healing time. I personally don't. I wait, and I wait until this heals. Now, where there's no consensus where there's less debate is when you're talking about the displaced fractures. And it's been shown in several articles, mostly in the sports world, that early intermedullary fixation will result in shorter time to union and faster return to sports with a mean of 7.5 weeks. Now, here's an example of a case that I treated non-operatively. Again, look, probable minimally to non-displaced, treated in a cast, and this is 1 month out, and there's some healing dorsally in the lateral plane here, and in the AP view, there's some healing in the medial aspect of the fifth metatarsal base. But if you look at this carefully, this one may be a little bit more extensive, a little bit more displaced. This, I went ahead and performed an intermedullary screw fixation. A few things about this type of fixation as far as the size of the screw. They range between 4.5 to 6.5 depending on how big the shaft is. A lot of cadaveric studies shows that the average size of the fifth metatarsal canal is greater than 4.5, so that's the rationale behind the smallest screw being 4.5 millimeters. Another pearl is you want to make sure that it's about maybe 60 to 70% the length of your fifth metatarsal. If you look at the top right here, there's a natural lateral bend to the fifth metatarsal, so if you go further than that, you risk you risk incarcerating through the medial cortex. And the starting point is key. This can be difficult if you don't have the right starting point. Nunley down in Duke talks about the high and inside technique, where your guide pin or your drill bit would start at the higher point of the fifth metatarsal, and your hand should be hugging the cuboid as an inside starting point. And that gives you the best chance of getting this shaft spanned by the screw. And this is where I start thinking about biologics. If it's a fresh fracture that is decided to take to surgery and perform this procedure, I don't usually go to biologics. But if it's a delayed setting, like if it's 6-8 weeks, there's still pain, there's still no signs of healing, I do tend to take bone marrow aspirate from the hip, injecting it into this area. And of course, those with high risk for non-union, your heavy smokers, your diabetics. I also go with a bone stim if they have high risk for non-union as well. The last part of the fifth metatarsal is the diaphyseal or the dancer's fractures. These have excellent healing rates with about 1.4% reported failure. You could see why, because of the increased mobility of the fifth metatarsal. It can accommodate deformities. However, again, it's the mantra in the literature: if it's displaced around 4 millimeters or angulated 10 degrees in the sagittal plane, then you could consider fixation. Here's an example of a non-op case. This is a fifth metatarsal diaphyseal fracture, treated in a boot, went on to healing in about 4 to 6 weeks. But here's one, and I'm sure everyone's seen this film before. What do? Can you leave it alone, or would you fix it? I've done both, and I'm now leaning towards fixing these, only because if you look at this carefully, there is a lot of shortening, and it's that gap. You could have healing if you treat it non-operatively up to here, but in a lot of cases they will still have pain because of an area that just doesn't have a lot of callus, and usually that is the proximal medial part right in this area. So what I started to do is plating these as well. Dorsal plating, I try to avoid lateral, as it would affect shoe wear. It can cause a painful lateral column. And the plate I use is the same that I use for the central 3 metatarsals, usually 2.4 with spanning the fractures as far as I can. Real quickly about navicular fractures, these are boat-shaped bones, mostly covered articular cartilage with multiple articulations, proximally with the talar head and distally with the 3 cuneiforms in the cuboid. The talar navicular joint is responsible for most of the hind foot motion, so as I said before, if you have problems with the talar navicular joint, you will most likely affect the subtalar joint. So that's important to think about, especially when you're thinking about fixing or when you're treating the body fractures in a little bit. Again, the mechanisms can vary. Bruce St. Georgian in Seattle really was one of the first to classify these based on where they're located. The only thing I left out in the slide is the stress fractures, which is a totally different beast on its own that has a lot to do with your metabolic state and the avascularity of the navicular. But as from a trauma standpoint, it can be, you could have a tuberosity fracture, which is where the insertion of the posterior tibial tendon is, capsular avulsion, which describes what it is. The capsule pulls a little piece of bone dorsally, and body fracture, which is what you mostly see from a trauma setting. Now, capsular avulsion fractures, we see this a lot. Usually they're very small fragments, and I immobilize them with anything any type of mobilization you want, boot, hard sole shoe. The bottom line is these are rarely fixed. When you do think about surgical fixation for capsular avulsion injuries, they're more for the bigger pieces, greater than 25% of the articular surface, or if they have pain despite conservative treatment, which is what this is here. This is a lady who had a capsular avulsion fracture, pain and really no signs of healing. So the way to fix these is through a dorsal approach and just lagging the piece through with a 2.7 screw, unless it's a bigger piece where you can go to 3.5, but most of these need smaller screws. Again, I keep these non-weight bearing like I do for the rest of the surgical foot fractures for about 4 to 6 weeks, and I advance their activities, wean them off the boot as the healing and symptoms would allow. Tuberosity fractures, these sometimes get confused with accessory navicular. The bottom line for these is that most are non-op if they're minimally displaced. And when you do think about surgical fixation for these, if they're big fragments, you could put a screw through it, 3.5 or 2.7 screws with a washer. Or in this case, you could treat it like an accessory navicular where you excise the piece, and in this case, you advance the posterior tibial tendon or the piece of it that attaches to that piece into the navicular with suture anchors. Real quick for the navicular fractures, the most important thing here is recognizing loss of medial column length. And in this case here, if you look at this CAT scan, you could see it's shortened in the medial aspect of the navicular here. And if that happens, you need to make a dorsal incision, bring it out to length, sometimes using an external fixator, and place any kind of fixation. In this case, I prefer, if it's comminuted, to use plate fixation. Certainly, if you're lucky enough to have just two large pieces, you could lag that again with 2.7, 2.4 screws parallel to each other. Last but not least, metatarsal phalangeal dislocations. These are hyperextension injuries, a little bit more trauma than what you would get with a turf toe. These are direct impact injuries. One of the more important or useful classifications is the JOS classification. This allows you to determine whether or not it's an easy reduction close or you have to open this. So when you're looking at the metatarsal phalangeal dislocations, you're looking at the intersesamoid ligaments. If it's in a type 1, if it's intact, that will be almost difficult to reduce, as you could assume that the plantar plate is incarcerated in a joint. But if it's wide or if it's broken, then it will be easier to manipulate the metatarsal phalangeal joint for a closed dislocation. Here's a case that it was wide, and so this would be a JAWS 2 that I was able to reduce and pin using a 6.2 K-wire. Here's one where you have you don't have widening of the sesamoid complex here that needed to be openly reduced, and a pin was placed for stabilization. The pin here is a 6.2 K-wire. I think the thicker the pin, the better for the first metatarsal. It's the biggest one, and you don't want it to bend during the post-operative period. Last is the lesser metatarsal phalangeal dislocations. A pearl here is to beware of second metatarsal phalangeal instability that you see with hammer toes and rheumatoid arthritic patients, as if you see it, it could be misread as a dislocation, but it's really just bad hammer toes and rheumatoid arthritis. But if it's just a simple a dislocation of the metatarsal phalangeal joint, they usually go in closed, and rarely you would need to open them or pin them unless it's a higher energy situation, just like this case, which happens to be an example from the first metatarsal phalangeal joint here. Again, if it's unstable based on exam, then you pin them as well. Now for the lesser toes, I do pin them again with either 4 or 5 K-wire, as it's the easiest one to pass through the tip of the toe into the metatarsals. Again, it's not that easy to do. Sometimes you skive, and I'm sure everyone's tried it. You either skive dorsally, planarly. The easiest thing that I found that you can do is to start the pin just under the nail, and that kind of centers you in the sagittal plane, and I think that's the easiest way to get this through into the metatarsal shaft. And again, I leave this in for about a month, and they start moving their toes. That's it. Any questions?